Ready,
Hey,
Doctor.
okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everybody. I'd like to thank Dr. Mekki and the Event Troop family for organizing this talk and inviting me to present on the preparedness in the medical imaging department during the COVID-19 pandemic. For those of you who do not know me, my name is Mohammed Mohammed. I'm a radiologist in King Abdulaziz Medical City in Riyadh, part of the Ministry of National Guard Health Affairs. I'm an abdominal radiologist and emergency trauma radiologist, as well as an imaging informatician. So I'm sure you guys have all been overwhelmed with information about the coronavirus as of late. We have all heard about the coronavirus and its impact in general on healthcare and on economy and society. The aim of this talk is for me to briefly introduce you to some concepts of imaging, medical imaging department preparedness, and what it means to be to have a preparedness plan for disaster and mass casualty incidences. We'll talk about the objectives of any good imaging preparedness plan, and how to implement those points, as well as the challenges and impacts that might not be so clear in the beginning regarding the pandemic and how it's affecting our healthcare system. And then I'll briefly touch on some food for thought about planning for de-escalation. So the novel coronavirus was first described in December 2019, an outbreak in Wuhan in China. The virus was dubbed the Severe Acute Respiratory Syndrome, Coronavirus 2, or SARS-CoV-2, and was responsible for the new disease identified as COVID-19. The number of cases continues to grow globally. Just as of last night, there were about 2.5 million cases worldwide, with just under 200,000 deaths. And in the kingdom, as of yet last night, there were just under 13,000 cases, which might have gone up by now. I didn't double check, and around 100 and some fatalities. So the exponential increase of this disease has been really concerning, as we haven't seen something like this in modern times. We were lucky enough during the initial SARS outbreak back in the early 2000s and the MERS-CoV outbreak a few years ago, that these organisms were not easily transmissible between people. However, this seems to transmit quite easily between person to person, which is contributing to the massive spread, and where such measures such as social distancing and quarantine have huge impact in reducing the transmission. So briefly, I'll talk about role of imaging, especially for COVID-19. So in COVID-19, imaging can take the role of either providing the diagnosis, guiding management, assessing complications, or looking at non-COVID-19 related diseases. So there has been a huge debate in the literature and in the community, should imaging be used for screening and diagnosis? However, by consensus in multiple international societies, all have agreed that there is no role in screening and primary diagnosis, no role for imaging in primarily diagnosing this, this infection. However, the situation may be nuanced and more complex, especially in areas with limited access to resources or places that are starved for molecular diagnostic tests. Recently, the Fleischner Society released a consensus statement on the role of imaging. Now, it is a very well-written paper with multiple scenarios and multiple caveats. I really implore all of you to go and read the paper. However, the main recommendations can be boiled down to: imaging shouldn't be used routinely as a screening test for COVID-19. However, in areas with constrained resources or an environment where access to testing is limited, imaging may be used in those cases. Imaging should be used in case of worsening of disease or respiratory status of patients. And as part of their additional recommendations, they do not recommend daily x-rays, especially in stable patients whose status has not changed. And CT is only indicated in patients that have worsened or have some functional impairment after recovery. And that when we see features suggestive of COVID-19, we should request COVID-19 testing in these patients. So definitely there's a role of imaging in patients with concern for disease progression or complications. We also use imaging for guiding management, such as in suspected abscess formations or assessing pleural effusions or cavitations. And then we use imaging for patients with non-COVID-19 acute presentations, because patients with stroke and heart attacks are not going to stop coming to the hospital. However, we have to that should be our priority throughout the imaging process. Okay, so, okay, there we go. So for us, we came up with an imaging workflow based on these guidelines from multiple societies, where basically the role of imaging was relegated to those patients that we need to assess complications in, or those patients where the diagnosis of COVID-19 was of lower priority. And an alternative diagnosis was being considered that would affect management. And one of the key points is that we preferred portable imaging at all times to departmental imaging, and that is to reduce any risk of infection. And we requested that all all requests for studies should be discussed on an attending to attending level. And that is to properly vet and assess the impact and the gain of imaging and what additional information it might add to patient care. So what is preparedness in medical imaging? So preparedness in general are a set of policies and procedures. They're designed to achieve sufficient capacity for continued operation during healthcare emergencies of unprecedented proportions. So we use these in cases where we are expecting a surge of our services that is beyond our usual standard operating procedures. These procedures should support care of patients affected by a mass casualty incidents. And we should be able to maintain radiology's diagnostic and interventional support across the hospital and health system. You do not want radiology to become the bottleneck in the department. If you are the bottleneck, you will have a huge backlog, which may affect patient care. We need to plan and prepare so that things go smoothly through our department to facilitate patient care. So now that we know what a preparedness plan is, what are the objectives of any good preparedness plan, especially during a pandemic? Well, our priorities are, one, to protect patients by reducing the chance of morbidity and mortality related to infection by early diagnosis and appropriate treatment. Prevent disease dissemination between healthcare staff, patients, and the community at large. We need to preserve our healthcare resources and capacity and manage essential equipment such as PPE. And we need to be prepared for any potential surges that might occur in patient care. Now, when should we start planning? Well, any emergency situation undergoes this kind of emergency management cycle. It starts with preparedness, moves over to response, then the recovery phase, and then mitigation. You can all guess that we're currently in the response phase because we're in the middle of a pandemic and we're trying to figure out how to best respond to that. But I want to focus on preparedness. Why? Because it's never too late to start planning. When's the best time to come up with your plan? Right now, if you haven't already, right? So as my mentor always says, hope for the best, prepare for the worst. So most of the literature on preparedness in medical imaging comes from our role in mass casualty incidences. Generally, even the preparedness of radiology in mass casualty is pretty young, with literature only stretching back to last 10 years. But in general, what happens is that you are in your standard operating procedures, your day-to-day routine, and an MCI is declared. This leads to an initial surge in demand for your resources. So this sustained initial surge can stress your system if you're not ready for it. Once that initial surge is met, the demand starts to plateau, and that becomes your new normal for a while. You'll be working over capacity, you'll be working in a stretched capacity. Once the initial incident is resolved or there's a stand down of the MCI, the initial threat is controlled, we enter a recovery phase where the demand of services starts decreasing slowly. And then there's a delayed stage for imaging needs, such as follow-up of complications or reassessment of patients that were affected by the MCI. And eventually we're going to return down to baseline. Now, this usually happens over a few days to maximum a week or two, right? However, in a pandemic, we have to take and stretch that out because it lasts much longer. The anatomy of a pandemic event is very different, where from your baseline, once the pandemic was declared, we enacted planning measures, or we on the fly ad hoc come up with planning measures designed to increase our capacity. And there is a sudden surge of our capacity, but quickly that falls down because, especially in this pandemic, our aim is to reduce exposure. The main way of reducing exposure is by reducing patients coming to the hospital and staying in the hospital. So this becomes your new normal, where there is a low level of day-to-day practice. You are reducing your cases to only essential cases. This may last for a while and eventually may lead to an unexpected or an anticipated surge in cases. This surge, by this time, you should have been prepared for it. We can use this lull in our demand for services to come up with our preparedness plan, so that when this surge happens, we're ready for it. The surge in cases will happen. We'll serve our COVID-19 patients. Then there will be a secondary surge. That secondary surge may happen while the pandemic is ongoing, but generally we expect it to happen once the pandemic is stood down. This will come, we'll discuss this later, from three main categories of patients, a major category of which are those patients that you rescheduled here so that you can control access to your healthcare services and improve your healthcare capacity. So that will plateau, and eventually we will return back to baseline. With that in mind, what do we need to do to implement a good preparedness plan? So communication is key to any good preparedness plan. There has to be a clear chain of command and a clear chain of communication. So in this example, by our oncology colleagues in our hospital, they drew a schematic of a communication chain, which is very similar to our communication chain, where the organization command center receives instructions and communicates directly with international agencies and governmental agencies, such as the MOH and the WHO. There is regular communication between them and each department. Our COVID-19 task force contains elements of our leadership who communicate directly with command center, and then we communicate directly with our departmental staff. and relate that information to our staff and our patients. So when you establish a task force, you have to make sure that there are key stakeholders from each level of management. There should be administrators, tech managers, nursing managers, radiologists, technologists, and nurses as well. Your initial priority should be to facilitate communication and centralize actions, because there's going to be a lot of noise in the initial days and a lot of information coming from different directions. If your staff knows that there's one area to look to for guidance, one source of news and action plan, that would help everybody. Now, how did we implement our preparedness plan? We tackled it by dividing it into three major categories. We divided it into general measures that apply across our department at all levels of our staff. Then we looked at staff-focused measures at different levels. So looking at radiologists, technologists, nursing, what each of their responsibilities would be, some unique responsibilities at each level. And then some modality-based measures where we look to kind of standardize some procedures in those areas. So let's start with some of our general measures. So it's important to have an escalation plan. You need to know that things may get worse. And when they do get worse, you need to have a plan. So we work hand in hand with our command center and followed their cues. Our hospital has a 4-phase disaster plan, with phase 4 being a disaster and phase 1 being an early phase of disease. So we had a stepwise decrease in non-essential services and stepwise increase in dedicating services to COVID-19 and COVID-19 patients. And one way to do that is to assign specific resources to COVID-19 patients, to separate the hospital into hot and cold zones, and we'll touch on those operational measures shortly. So we reduced all non-critical outpatient examinations, and we did that by discussing the importance of these examinations or the need for these examinations with our colleagues and referring physicians. We didn't stop any referrals from oncology or transplant services or dialysis services, because these are critical patients. However, what we did was we did filter the patients that do not require immediate studies by discussing with our colleagues and prioritizing those that are not on active treatment or whose imaging won't impact their management directly at this time. Those that could be deferred were deferred. And there was communication with patients through social media, SMS, and phone calls. Those patients that were in the intermediate category where imaging may help were offered the option to come in and get their appointment, or to defer their appointment if they so choose. Then we established a workflow in our department for when these patients come. And the basic idea for this workflow was, well, we don't want to increase the risk of transmission to other patients or our staff. So we screen these patients. The screening starts actually at home. Our unit assistants call them and ask them a bunch of questions based on our acute respiratory illness screening form, which I'll share with you in a second. Now, if they score high, we ask them to stay home and go to the flu clinic instead of coming for their appointment. If they score low, they come in and proceed with imaging. Now, what happens if they didn't score high enough or they didn't answer? Well, they come to the hospital and there's a second line of check where our nurses at the department screen them again with the ARI screening form. The results are recorded in the hospital information system. And based on their score, we either proceed or do not proceed with the examination after consulting with our radiologist. The other thing we did was assign specific isolation rooms. Now, let me be clear, by isolation rooms, I do not mean negative pressure rooms. I mean rooms that are away from foot traffic, that are isolated enough that patients can wait there without affecting our other non-ARI or non-COVID-19 patients. So we assigned rooms that could be sealed away from common foot traffic, that have a door, and are easily monitored by the nurses. So we can either keep the patient there while they're waiting if they need to go ahead for the examination, or they need to be interviewed by our radiologist or the referring physician. And they can wait there after the examination before they are referred to the flu clinic. And this is an example of the ARI screening form, which was initially developed during the MERS-CoV outbreak back in in 2014, 2015. And we still use some of the MERS-CoV questions because there is still some sporadic community transmission. So it's good to screen for both, as the initial presentation may be quite similar. Other operational measures, like I discussed, was dedicating specific rooms for confirmed and specific portable machines for confirmed and suspected COVID-19 patients. We prioritize portable imaging and portable interventions over departmental ones whenever possible. So we do not want to bring the patient or move the patient, which increases their risk of spreading the infection. And we postponed all non-essential leaves for our staff as per our institutional and governmental mandates, so that we can maintain a surge capacity and a backup capacity if needed. Resource management is essential to any preparedness plan, because you don't know what resources you're going to run out of when, right? If you do not have a plan, if you do not have a clear list, this is going to be a nightmare. So what we did was centralize all our essential consumables and PPEs. We know that the most valuable things are the PPEs and the cleaning material. And as such, we decided to centralize them in one location and distribute them as needed to our sections. With that, we can monitor the consumption and generate weekly reports of that consumption and monitor appropriate use, so that we know that we're not overusing or overutilizing essential materials such as PPE, such as N95 respirators. As for our departmental-wide infection prevention and control guidelines, there's huge debate, which are the appropriate measures. Should we do airborne precautions? Should we do droplet precautions? It's a constant debate. Well, you have to look to your infection control department for guidance in this. So we sat down with them, we shared our infection control policy in the department. They helped us develop it and modify it based on the best evidence they had. And we look to them every week to update us on what should be the appropriate PPE. And for us currently, it is droplet precautions for suspected COVID-19 patients, and airborne precautions for all confirmed patients or those in critical care areas, such as ICU, like the resuscitation bays and emergency, or intubated patients, or patients undergoing aerosol generating procedures. We organized in-service education and drills and simulations for all our staff, for educating them on appropriate donning and doffing of PPEs and which PPEs to use at what time. And we created a staff survey, which we released to our staff very recently to assess their knowledge on COVID-19. And all medical imaging staff are screened whenever they enter the department for ARI symptoms. All our staff got an N95 respirator fit testing and training, and those that did not pass were offered PAPR devices, and they were trained on appropriate use. We also looked at how to reduce infection transmission in our examination rooms. Now, one of the main things that we looked at was the number of air changes per hour, because that determines how long the room should be sealed after a procedure, because it shows you how often is the room air completely cleared. And based on the literature, an air change per hour rate of 6 to 10 should require a room ceiling of approximately 1 hour to make sure that there are no floating or suspended droplets still in the air. So we looked at our air changes per hour. Those that had greater than 10 to 12 were closed for about 30 minutes. Those that were between 6 to 10 were closed for around an hour. And after that, the technologist goes in with appropriate precautions and wipes down the machines as necessary. We also requested portable HEPA filters to be brought into the designated COVID-19 rooms after discussing with our colleagues in infection control and in biomedical engineering. And although there isn't much evidence out there, the feeling was that they will increase the air clearing rate and reduce the risk of suspended droplets in the room. And so we have them activated before and after any patient leaves until the room cleaning is done, especially in CT and intervention and X-ray. But for MRI, we do not have any compatible portable HEPA filters. So in MRI, we actually just prolong our closure according to the ACH. And we outlined the responsibilities and appropriate cleaning material and designated each staff member their cleaning responsibilities for the room. As far as team management is concerned, we aim to reduce the number of staff at any given moment in the hospital. Our residents were mainly delegated to emergency and on-call coverage primarily. And we divided our radiologists and fellows into isolated teams with weekly rotations. Ideally, what you want is a complete team consisting of your radiologist, your fellow, your resident, your nurse, your unit assistant, and your technologist. And that's impossible to do across the department. But the two areas that was quite applicable in was breast and women's imaging, as well as interventional radiology. So those two sections had completely isolated teams in complete rotations that worked together at the same time and were at home at the same time. Whereas for the other sections, the technologist, unit assistant, and nurses mainly forms a single team unit, whereas radiologists and their fellows and residents formed another unit. And we made sure that everybody maintains the appropriate social distancing measures and reduce any cross coverage between the two teams. Our IT supported us in providing our administrative staff with remote VPN access so they can access their desktops from home and continue to work from home while reducing their exposure risk. And by establishing remote imaging access for radiologists, we can currently view our images from home, but we cannot report or approve reports from home. So it is a good quick backup solution, but we still need to be there on site for final reads and any decisive decisions. We transitioned to virtual meetings and tumor boards for most of our tumor boards. There were a few hiccups in the beginning, but it was a learning process, and now it's pretty smooth, and we do most of our tumor boards that way now. And we looked for a shared platform for teaching, which our IT group helped us with by providing us Microsoft Teams, and we also use Zoom for some of our teaching sessions as well. Now, some staff focus measures that we looked at were radiologist-based measures, where we looked at we had our radiologists look at appropriateness for all imaging requests, because we needed them to filter any unnecessary imaging or look at whether a portable imaging modality could sufficiently answer the question so as to reduce departmental exposure to disease. All our radiologists always maintain social distancing measures by either reporting from personal offices, discussing over the phone, and making sure to handle all meetings and consultations virtually as much as possible. For our technologists, as they are some of our most frontline healthcare workers in the department. They are constantly dealing with patients face to face, and they are the most at risk for exposure. They were the main people we targeted with infection control policies and procedures, and making sure that all patients are screened properly. So they confirm whether all patients received an ARI screening form before they even come onto the scanner. They confirm any isolation precaution status for all inpatients or ER patients. It is their job to adhere to the imaging workflow that they helped develop, which I will discuss one example of shortly. And they are assigned the proper cleaning. They follow the proper room cleaning guidelines, especially for cleaning the gantries, the machine itself, the table, and the injector, as well as probes or any material related to the machine, to the imaging modality itself. Our nurses screen all outpatients, visitors, and staff before entering the department. They really teach us and educate us and make sure we are performing correct infection control and prevention practices and policies. And they ensure that our technologists are adhering to the imaging workflows, and they are assigned specific cleaning measures for the procedure rooms following a patient's departure, especially the monitoring devices, the blood pressure cuffs, etc. So we have assigned specific roles for each member of the team. And our housekeepers are generally responsible for cleaning the floors and the non-medical equipment in the room. Now, some of the modality-based measures I mentioned before, the logistical workflows that were developed, and these were necessary to ensure that any patient coming to the department has a specific access path that reduces their contact with any of our non-COVID-19 patients or any of our healthy staff, and make sure that they do not wait too long in areas where they can increase their risk of transmitting the infection, and that the specific machines are prepared for handling these patients. The goal is to reduce the risk of exposure or contamination by creating hot and cold zones in each area in the radiology department, and reduce risk of patients interacting with non-COVID-19 patients and staff. So one example of that was our CT scan room plan, where we assigned a hot and cold zone where our control room is essentially clean. There's a technologist in there who only stays in the control room, does not assist in positioning the patient, does not enter in the patient waiting area. The patient would enter into the anteroom with the staff accompanying the patient. Here, a technologist already donned for the appropriate isolation measures, waits for the patient. They enter into the scan room together and position the patient, make sure everything's okay, lines or tubes are in place. Then they come back to the anteroom. In the control room, the other technologist would be there. They would perform the procedure. If any intervention is necessary, they could communicate through the door with the staff waiting in the anteroom, but would not enter there. Usually the ICU physician or the accompanying physician and a radiologist would be there in the scan room with the technologist to help with any further imaging needed, or to direct any intervention needed for the patient in the scan room. And we developed similar protocols for all modalities in our department, including nuclear medicine, MRI, and intervention. Other modality-based measures, we made sure that all protocols, especially in things such as CT, where we have multiple chest imaging protocols, we had a clear COVID-19 imaging protocol, so everybody uses it, decreased variability, especially since they're done on the one dedicated scanner. We also started performing X-rays through isolation room glass. And this was initially described by the University of Washington Radiology Group in Seattle at Harborview. And it was used initially in the 2014 Ebola outbreak. And this technique is quite ingenious because it reduces the PPE consumption and the downtime between patients, as well as reducing risk of contamination and disease transmission. The technique allows for imaging the patient from outside of the room, where the patient lies, the detector is positioned behind the patient by the nurse who dons the appropriate PPE, goes into the room, positions it with guidance from the technologist. The nurse waits in the room behind the patient about 2 meters away while wearing a lead apron underneath their PPE. And the image is taken, it's quality checked quickly by the tech, and if appropriate, the nurse disinfects the detector, which is covered in 2 plastic bags. The outer plastic bag is disinfected by the nurse. The inner plastic bag, or the detector with the inner plastic bag, is pulled by the technologist without touching the outer plastic bag. Then the inner bag is disinfected, the detector is removed and disinfected again. So all you end up disinfecting is the detector without needing to disinfect the whole X-ray machine, which would take a very long time and can speed up the process of imaging multiple patients in a row. Our ICU nurses and ward nurses are very cooperative with us, and that is one of the key things needed to make sure that this technique succeeds, is cooperation from all involved parties. They were very excited because it does reduce the consumption of PPE, and it does reduce kind of the risk of cross-contamination between multiple patients. We use it in the ICU and we use it in the wards as well with these small slit-like windows or slightly larger square windows. It works very well with all of them. And these are some examples. These are some ward patients with slit windows. Another one here, this patient's so you can see that most of the time we have our text write the comment through the glass. This is another ICU patient that's intubated and was unable to be mobilized, but still the X-ray came out very nicely. And we can use it for a baseline or follow-up examinations. So this is a basic approach of how we went around implementing our preparedness plan. So we tackled primarily how we make sure to keep our staff safe, how we utilize our resources, and how we make sure that that we can sustain our services throughout the pandemic. But there are some challenges and some hidden costs of this pandemic, which we do not think of on the outset of the situation. So although like the initial costs of infection and consumption of healthcare services and mortality and morbidity is very clear, the mental health impact of COVID-19 is something that should not be ignored. Social isolation and a sense of losing control over one's day-to-day life can be overwhelming. Healthcare workers in particular, although they might fear of getting infected themselves, may also have a greater fear of infecting their loved ones rather than themselves. The reduction in their day-to-day duties or their sense of helping patients, the reduction in their sense of helping patients may lead to a reduced sense of professional satisfaction. And these altogether may have huge mental health impacts on our healthcare workers. That's why communication is very essential, especially from leadership. If they show communication and support, as well as confidence from leadership about the plan, about what we're doing, how we're doing it, how we are going to tackle things, This can help boost confidence. Other initiatives, such as setting up well-being hotlines, providing seminars, how to deal with such stressful situations of mindfulness and searching for mental well-being, are excellent initiatives that we should start transitioning to. It's very difficult for us as a culture to adapt to this because this is not our normal, but this these mental health impacts are already starting to show in a lot of our healthcare workers, and trying to mitigate that early on may be a great investment. We set up a mental health well-being hotline in National Guard. Our leadership set it up for all employees across the enterprise in all regions of the National Guard Hospital. And any employee can benefit from these resources. The other thing to keep in mind is that the patients that we rescheduled, they're going to need to be re-imaged. And we might not be ready for that if we don't have a plan. In the recovery phase, once the pandemic is standing down, once we are trying to normalize our services, we're going to be hit by 3 waves, mainly consisting of the unworried unwell, which is a term I adopted from my colleague Siobhan O'Neill. And we're already starting to see that. Some of these patients may not want to come to the hospital because they feel sick, but not sick enough to think that they want to risk getting infected. And that fear may keep them from coming in. So instead of seeing a nice acute appendicitis that can be taken out in 5 minutes, we're seeing more gangrenous appendicitis or perforated appendicitis or a perforated gallbladder or a stroke that's beyond mechanical thrombectomy now. The rescheduled patients and the rescheduled patients is another concern. So we have to have a plan. There are a lot of patients that we've rescheduled. How do we maintain services for the coming patients, and how do we maintain services, or how do we catch up with the needs of these other patients? So we have to start thinking of plans from now. Do we increase our staffing numbers? Do we hire some locum staff? Do we provide overtime shifts? These are all things that you need to discuss in your department and figure out what's the best solution for you. And then the post-COVID-19 recovery. So because this is a new novel disease, we don't know the far-reaching impacts of this disease. We don't know what these patients will need after they've recovered, and we're still starting to learn that. So these are things that we're going to learn together. Of course, there are residency impacts where our residents are not getting enough education. However, remote teaching sessions may fill some of those gaps, but it's important to include them in that discussion because they're the key stakeholders. So striking the right balance between overwhelming them with too much remote sessions or underwhelming them by not enough engagement is very important. Deciding when to reintegrate them will depend on your return to normalcy in the department. Should their exams or assessments be postponed or altered in a way that better serves them must be discussed at a regional and an institutional level. Of course, research has come to a halt in many institutions, so now might be the time to pivot to other more relevant projects, such as COVID-19 related projects, especially multi-institution initiatives. But now might also be a time to focus on quality improvement in your department, because things have slowed down so much. You can go and look at your processes, your procedures and policies, and start refining all of those and seeing if, what stays, what goes, what works, what doesn't. So after this is all over, we have to figure out what's going to be the new normal. Are we going to continue working from home? Is remote education for residents and weekend sessions for them the best way to teach them? A lot of things will change, and we have to figure out what works best and what doesn't. Backlog will require prioritization. We're going to need to figure out what works best for our operational needs. And mental health is a huge priority. Some of our staff might be burnt out. Some of our staff may have PTSD. This is a taxing situation. They may be impacted economically, or the hospital might be impacted economically. That CT scanner that you were supposed to get in 2 months, You might not get it. You need to figure out what is important after this is over. And then a debrief and after action review will be essential. It'll be important to dissect what has happened and figure out what worked, what didn't, what needs to be improved, and then refine your preparedness plan, because you want to be better prepared if this were to happen again. So in conclusion, the pandemic introduces many new challenges, but proper planning and teamwork is key to overcoming this situation. Practice, practice, practice. Drill your staff, run simulations. These are key to making sure your team is ready to face any situation. These are difficult times, but be kind to yourself and be kind to others. I'd like to acknowledge everybody who's assisted in the whole process. There's a huge team of colleagues and friends who have helped us work together to make sure our department runs properly and keeps everybody safe during this time. And as you can see, it's a huge list. And so it's not a single, it's not a one-man show. It's a team effort. And it's a team effort that requires communication and dedication. And I encourage you to look at what you can do and what team you can build that can help you fight this situation and other future situations. Thank you, everybody, and stay safe. And you can contact me on any of these methods if you want to ask any further questions after this is over. Thank you. So I don't know if we'll be taking questions, or is there a way to take questions? If and
Thank you very much, Dr. Mohammed. I think the session is over since no questions. Thank you very much.
Thank you.